and on the left side between 28 and 37. CT simulated fluoroscopy is done in 2013. This is approach used for if there is a possible vital organs or major vessel injured. We first, pre-procedure, we do CT at T12 with our target point is the right side of the lateral side, right side, the lateral side of the superior articular process, 3 cm on the skin, and the angle is 18 degree. We should measure the distance between the target point and the anterior margin of the vertebrae. Then start the fluoroscopy also by the 18 degrees at T12 with angiocast on the right side and the same depth. The needle depth will be the 2/3 of the AP diameter, and we will inject the contrast. It will spread anterior and lateral and across the midline, and we use 10 ml lidocaine and followed by 15 ml ethanol. This is the advantage. It is done in the lateral position with good needle proximity and less risk and less time, and it is easy. CT guided anterior approach, it's safe and excellent, and you inject caudal to the celiac axis, closer to the superior mesenteric artery, with incidence of paraplegia is 0.15%. But it had more radiation, continuous guidance is not possible. The success rate of the celiac plexus is 80%, and the evidence is the highest level of evidence with positive recommendation, 2A positive. It has long-term pain relief and better life. Cryoablation, if it is cryoablation under CT with 2 cycles of freeze-thaw below 150 degrees, it dropped the visual analog score from 10 to 3, and the patient still stable for 6 months. This is our university. Splanchnic approach by the radiofrequency splanchnic nerve, minimally invasive and effective and successfully repeated for the functional abdominal pain especially. Splanchnic nerve neurolysis with ethanol, more effective than transaortic approach. Splanchnic nerve neuromodulation with implanted leads at T11. It is 2P positive evidence, weak methods, and positive recommendations. We can do CT splanchnic nerve block if the fluoroscopic guided splanchnic nerve block had insufficient result. Chronic abdominal wall pain, we can do TEP neurolysis, quadratus lumborum block, a dorsal radiofrequency pulsed, dorsal root ganglia pulsed radiofrequency for anterior cutaneous nerve entrapment. Lastly, vagal nerve stimulation, it inhibits the inflammation and the oxidative stress, activate brain region that oppose pain matrix, and it is anti-nociceptive. There is another method, central analgesic mechanism using counter-irritant by using somatic test simulation and somatic conditioning stimulation in irritable bowel syndrome, and it causes negative effect. When you submerge one hand in 50-degree water and the other in 12 degrees counter-irritant, and it causes negative effect. The lastly, in refractory cases, intrathecal catheter and spinal cord stimulant. Thank you.
Thank you, Dr. Saheb, for a nice lecture of covering upper abdominal pain. Now I invite Dr. Goel, covering anatomy and physiology of visceral.
Thank you, Dr. Gaurav Sharma, for an earlier nice introduction. And actually, Dr. Gaurav and Dr. Saheb, they have made my lecture a little shorter now because they have covered a great part. and the organizers for giving me an opportunity to talk about this very important topic of visceral pain, and in fact, giving all of us a very good platform to exchange the ideas, concepts, and knowledge to share and exchange. So, Dr. Goyal. See, all of us know about pain. We have discussed definition of pain a lot of times even today, that it is sensory and emotional experience based upon tissue damage and a potential tissue damage. That means when a patient complains of pain, he has not only complaining about his present physical pain, but he also adds up the previous experiences of pain which he might have experienced in his or her previous life. So, and as we know that pain is one of the most common, rather the most common symptom which brings the patient to a clinic. And out of the various pain syndromes, visceral pain is the most common type of pain, which actually we found the maximum number of patients in our clinic for day-to-day practice. So, whenever a patient comes to us with a complaint of fullness or discomfort in the abdomen, discomfort is a very common word which is used by the patient whenever he comes comes to a doctor. So whenever he complains of a discomfort in abdomen rather than pain, or pain in abdomen, so whenever he describes his pain, it's dull. He's not able to localize it properly. Whenever you ask him where is the pain, he usually keeps his hand over his abdomen and he just indicates all over the abdomen, pain all over the abdomen. So this is a very characteristic feature of a visceral pain, that it is poorly localized, very diffused, dull aching. So in first instance, maybe it becomes very difficult to think about the source of pain, from where it is coming. This is a very characteristic feature of visceral pain. As I said, now what is the broad difference between the cutaneous, the somatic pain or visceral pain? As we know that crushing, cutting, burning, these are the various features which is described whenever we talk about the somatic pain, and in fact they are well localized. Patient what is more important than the cutaneous receptors, somatic pain receptors of the somatic pain, they respond to such stimulus when we give stimulus in the form of cutting the tissue, burning the tissue. But whenever these stimuli is being provided to the visceral pain receptors in the viscera, probably viscera does not respond. They do not carry the sensation of these stimulus because they do not have receptors for cutting, crushing, or burning. Rather, the receptors in viscera, they respond to different kind of a stimulus, the distension or pressure, like mechanical stimulus. There's too much of pressure or distension. Other kind of stimuli like maybe inflammation, ischemia. These are the various things which actually stimulate the visceral pain receptors. Many forms of visceral pain are particularly prevalent in women and are associated with their reproductive life, period pains, labor pains, etc. For both men and women, pain of internal origin is the number one reason to consult a doctor. So whenever there is pathology in visceral pain, viscera, it is poorly localized. But when this pathology goes on increasing, the disease severity increasing, the process is goes on to involve the parietal of that viscera, maybe parietal peritoneum or further parietal. Then the pain starts become localizing. So it is not always that the dull aching pain is visceral pain. In the advanced stage of disease, when the parietal is involved, it becomes localized. So it's the parietal pain, which may be a component of visceral pain in overall picture. It is caused by the irritation of fibers that innervate the parietal peritoneum, and in contrast to visceral pain, can be localized. So as the underlying disease process evolves, the symptoms of visceral pain give way to the sign of parietal pain causing tenderness and guarding, particularly in abdomen. Referred pain is a very important component in visceral pain. Always, in most of the times, whenever there is a pathology or a visceral pain, it is usually also manifest in terms of referred pain. Referred pain, as we know, that pain on a side different from the site of pathology or site of origin of pain. So it is called the referred pain. In later slides, we will see how this referral pain and visceral pain, they coincide, and it is both of the things are found whenever there is a patient of visceral pain. And researchers have told us that there is a basis of this visceral pain is the embryologic origin of the visceras. Visceras originally from which part of the body they have been originated. So those visceras are actually involved in the referral pain, pathology in one organ and referral pain in that particular organ, where the origin of the embryological origin is common. So these are the various terms which we use to describe the visceral pain. Maybe sudden, gradual, dilating, pleuritic, depending upon the source of pain. So coming to the basis of anatomy and physiology of visceral pain, as I said that visceral pain receptors in the viscera, they respond to distension, ischemia, inflammation, or the traction of the mesenteries. And earlier we used to think that not all visceras are pain sensitive. Earlier we used to think that hollow visceras, they are more pain sensitive, they respond to painful stimuli as compared to the solid viscera. But now, as we go on increasing our knowledge, depending on the various research and studies, we know that solid organs also respond to a painful stimuli, something like liver capsule. Whenever there is a liver pathology, there is an inflammation there. They also respond, they also send signals to, which can be perceived as pain. So they refer to body wall, diffuse, poorly localized. And another very important feature, the involvement of the autonomic symptom. Here it is one area where there is a complex interaction between the